talking about proactive planning in the midst of this COVID outbreak. I have nothing to disclose. So I think, like Kate said, kind of why now? All of you are probably already having fantastic advanced care planning discussions in your practice with your patients outside of COVID. So what has COVID introduced to this situation where now we're having these advanced care planning discussions, or ACP, in the midst of all of this stressful, challenging craziness, I think it also provides us a chance to invite our patients and families to talk about something that is causing fear and stress and disrupting all of our daily lives. So advanced care planning can actually open a door to have some of these talks and maybe even mitigate some of the fear and uncertainty that could come up in the future if we're not having these talks and we're not as prepared and we don't know what our patients' goals and values are. So I think advanced care health planning can really be helpful during this time period in a number of ways. So I think it's helpful to sort of orient ourselves to our current situation. I know in Seattle, we've been talking a lot about conventional capacity, contingency capacity, and crisis capacity. And these are really disaster planning terms, right? So conventional capacity is when everything's normal, we have all the resources we need, and that's what I think of as pre-COVID state. Contingency capacity is where you're doing things differently because you are now in a state where you're needing increased resources, but you're not quite yet at crisis capacity, where now your resources are thin and you are having more demand than you have supply. So if you think about rationing, that's when that occurs, especially in the setting of ventilators. And I would argue that maybe New York is kind of in that crisis capacity state. Italy was. And documenting advanced care planning early when you're in conventional and contingency states might actually help prevent crisis state, right? So if we flatten the curve a little by having these advanced care planning conversations with people who would otherwise, if we didn't have this conversation, might be put on ventilators. Now we know there are certain folks who would prefer not to be put on ventilators or not have their life prolonged in certain ways. And we can prevent them from being put on treatments they don't want, and thereby flattening our resource curve as well. So accomplishing two things. I would argue that we're in contingency capacity right now in Seattle, and I'm wondering if a lot of you guys are kind of there as well. This was our most recent kind of curves that we've been looking at, and you can see that green line is the number of ICU beds, and luckily we have managed to stay below that. There we go. Okay, so again, I think a lot of you have already had some of these discussions, both pre-COVID and maybe currently you're having these discussions. And I just kind of wanted to have us collectively sort of reflect on or think about, when's the last time you had a conversation with a patient or surrogate decision maker about goals of care, particularly related to COVID during this time? And how did that discussion start? Did you bring it up, or did the patient or surrogate initiate the conversation? This is on everybody's minds. And then how did it go? Did it bring up any strong emotions for you? Did it bring up any strong emotions for the patient and surrogate? Because these discussions are scary. They can be challenging. COVID is scary. Did you use a more parental or directed approach to your conversation, maybe with a patient or family or surrogate decision maker whose loved one has more health conditions or is at higher risk? And by the end of the conversation, did you understand what your patient's values are? And would you have done anything differently? And these are just the tools and questions that we use as palliative care providers to reflect back on maybe a goals of care conversation that we had, and to see, is there anything we would have done differently? Is there anything that we did well that we would want to take forward to our next conversation that seemed to work well in this conversation? So just some helpful things to think about, because I'm sure you guys are already having these conversations, and things probably went well in some, and maybe in others you thought of things that you could try differently in the next conversation. So just a reminder that our overall goals in primary palliative care are really to figure out what our patients' values are. So we tend to think of their values as, what are they the expert in, their values and their goals, knowing those. And we think about the values triad. So some patients really err on the side of living as long as possible being a goal, longevity, remaining as independent as possible. I wouldn't want somebody having to help me go to the bathroom. I would never want to end up in a skilled nursing facility. And other patients who maybe have serious illness, their goals lean more towards comfort and symptom management. What treatment options best match our patients' goals and values? That's what we're experts in, right? Which is why a lot of primary palliative care is done by primary care providers. And palliative care providers include physicians on their team, and nurse practitioners and physician assistants, because we have some background in what these treatment options look like. And together, knowing our patients' values and goals, what our main goal, our ultimate goal in palliative care always is to provide goal concordant care for our patients, to match those values and goals to match the treatments that we have to our patients' values and goals. So one of the palliative care approaches that we have been talking about collectively as palliative care providers is, a big consideration is, what are the risk factors for our patients? So consider patient factors. Are they a low-risk patient who's maybe in their 30s or 40s, no other health conditions? Are they more at moderate risk? Maybe they have some cardiovascular risk factors. Or are they a high-risk patient? Maybe are what we think of as maybe our elderly patients, 80 and older, even 65 and older, unfortunately, in the COVID patient population, with concurrent cardiovascular or respiratory illness, because this will change the way you consider presenting prognosis and your concerns or worries for your patient and the outcomes that they might be able to expect. So one of the main websites that I think a lot of people turn to or use as a guide is Vital Talk, and that was started by Tony Bach and Bob Arnold. Tony produced this new, he loves acronyms, so he produced this new acronym, CALMER, in regards to discussing goals of care with in the setting of COVID, I should say. So I'll just go through CALMER because I think it's a nice framework to start thinking about how to have these conversations, but it is a very general framework. So after I go through CALMER, I'll just give some extra kind of general palliative care pearls, tips and tricks, and hopefully that'll kind of help fill this in. So as a starting point, CALMER, C is for check-in. So a good opening question might be just, how are you doing with all of this, right? And Tony refers to this as kind of the emotional temperature check of the visit. So you kind of can get a sense of, where are you starting from? Where is your patient starting from? How are they doing today? So again, just doing that initial open-ended check. And then the A stands for, ask about COVID, so ask about the elephant in the room, approach directly. And I'm using a lot of examples and quotes because I think it's very helpful to have actual words and language and sentences that you can keep in your back pocket. So if your mind goes blank during one of these patient visits, you can kind of think about like, oh yeah, I read about, trying out this sentence to open up the dialogue. So I like to actually include actual quotes that you could you could use as tools. So what have you been thinking about COVID and your situation in particular, especially if they have other health conditions present? So the L stands for lay out the issues. So is there anything that would be important for us to know if you got really sick from COVID? Or, you mentioned COVID. Let's talk about that. There's a couple things I think could be important for us to prepare for and talk about. And then the M stands for motivate, patient to choose a proxy and talk about what M matters. So if nothing else, it's so helpful for us to have a either legal next of kin or durable power of attorney for healthcare in the chart to go to if our patients end up in the hospital and we can't talk directly to them. It's so nice to already have someone that the patient trusts to make these medical decisions for them, either listed or included in advanced care planning. So do you have someone you trust to make important medical decisions for you if you are too sick to speak for yourself? And we used to ask about family. Do you have a family member? But Tony and the Vital Talk team has done a lot of outreach to the general public, and they found that that was kind of triggering for some people. And so really asking, do you have someone that you trust, especially for folks who maybe are estranged from their family, is found to be a more helpful question. E is for expect emotion and acknowledge it. So the other acronym that Vital Talk really loves is the NURSES acronym. And if you're not familiar with that, I'll go over it on the next slide. And then R is for record the discussion. And it doesn't have to be a long note. The Vital Talk folks like to emphasize that even just a brief note can be incredibly helpful for your colleagues elsewhere in the healthcare system, because any information, I think documenting values and goals is helpful. So responding to emotion is actually one of the most important things that we do in palliative care, because a lot of times I think when I rotate on the internal medicine service or the geriatric medicine service, I don't do this quite as well when I'm rounding on my patients. But in palliative care, one of the things we like to emphasize is responding to emotion, because a big part of emotion is these are strong feelings. We like to talk about being on the emotional channel versus the cognitive channel. So if you're having these strong feelings, if you're angry, if you're scared, if you're stressed, a lot of the medical information that we're trying to relay then to our patients and families is just not going to be picked up because they're struggling with these big emotions. And when you are in kind of that emotional tornado or storm of emotion, you're not really able to lay down those new memories of cognitively what people are trying to relay to you, information and details. So being able to diffuse some of that emotion is actually a big part of our work. So responding to emotion. And again, Vital Talk loves its acronyms, and this is one that we use a lot. So NURSE as N is for naming. So something like you sound worried or concerned, and we try to, take the emotion that you're seeing and dial it back a little. So if somebody looks angry, we often will say, you sound frustrated. So dialing it down just a notch. And understand you normalizes the emotion or situation. So we always try to avoid ever suggesting that we completely understand someone else's experience. Like, oh, I totally understand. That's something that we 100% try to avoid saying. So saying something more like, I can imagine this is really difficult news to hear, because rarely do we ever, again, completely understand another human being's situation. R is for respect statements. It's an expression of praise or gratitude about things they are already doing. S is for support. So expressing, again, what we can do for them. And this idea of non-abandonment, we'll be with you every step of the way. We'll do everything we can to support you through this illness. And E is for explore. So that's really a nice kind of open-ended, can you tell me more about that? Especially if somebody says, I'm really scared, or this is really upsetting. Sometimes this, can you tell me more about that, can get you a little deeper and can get you some more information. And then the final S is for silence. And this just creates a nice space for people to share more. Don't let it go too long, because then I think it just becomes uncomfortable. So use it thoughtfully. I did want to provide just some helpful talking points for palliative care pearls. And this is more for your moderate or high risk patients. So how do you discuss or present kind of some serious news or prognosis, or maybe your patient is on a slightly different page than you are as far as what you think might be a realistic expectation for if they were to get really sick and end up in the hospital. So I wish statements are nice because they allow you to help align more with your patient. And we think about, not taking away hope from your patient. And this is something that, again, instead of kind of arguing with your patient about something that you don't think is realistic for them, it allows you to, again, align, be empathetic. But an example is, I wish we had better treatments. I wish we had more testing available. I wish we were in a different situation. So something as simple as that can just move the conversation forward and provide support for your patient or family member. Similarly, I worry statements are very useful in our work. So it allows you to express your concern that, again, the patient or family member's stated goal might not be possible. So it allows you to deliver serious news in the form of a headline. So because of your other medical conditions, I worry that even with maximal medical support, you would not survive. And then often what we do is we allow for a pause and just see what comes back. And a lot of times when you're delivering a headline or serious news, you get silence and then some emotion, and that can be anger, it can be sadness. So we encourage our providers to just expect to see emotion, and then go back to nurses and be able to acknowledge that emotion, because again, we want to, in the end, be able to deliver some cognitive information to our patients. But if they're so scared from what just talked about, that's not going to necessarily stick or be possible. Okay. So here are some things that I thought might be helpful. Elicit and map out values for patients, because again, we think of values as what our patients are the experts in, what's most important to them, what matters most to them. So if we can kind of figure out what's most valuable to them, then we can, again, align our treatments with their values. So a helpful question is often, especially in the setting of the coronavirus, if you were to get the coronavirus or another serious illness and become so critically ill that the doctors thought you were unlikely to survive, what would be important to you? And here are some examples that I sometimes will lay out for people, because again, these examples kind of help normalize that here are some things that other people think about, and that way patients don't feel like their ideas are necessarily so far off the map. And it gives them examples to choose from. So some people would want to try all life support treatments to live as long as possible. And see, this is the longevity statement. Other people would want a trial of life support treatment, but if they weren't working and were only causing suffering, they would want them stopped. So this is kind of a middle ground time trial where I'd like you to try to help me recover from this, but if you're seeing that things are not working, I'm not somebody who would want to be on machines forever, and please don't do that to me. And then the third statement is other people would not want artificial life support treatments, who would want to focus on comfort and a natural death, and you can see that's the comfort focus statement. I would encourage everyone not to be afraid to make a recommendation. This is something we also do frequently in palliative care. So it's something that we call shared decision making. And it's really using the patient's values and then your knowledge of the treatments. And again, trying to match those, right? So an example is, given what I know about your medical situation and what you said is most important, would it be okay if I made a recommendation about next steps? That just opens the conversation and then again gives control back to the patient or family in a situation where it feels like they have no control. Any control in the conversation that you can kind of hand back to them is helpful. So one of our other tricks or tools is to ask a lot of permissions. So would it be okay if I made a recommendation about next steps? And this also helps because you're kind of providing hopefully a solution to help move forward. And this plan should be based on values that you elicited. Again, you are the expert in the treatment and you can probably find an option that matches patients' values and goals a little bit more than some of the other treatment options. And then consider using the PULSE framework for potential plans. So if you look at the PULSE form, Part B kind of breaks down into full treatment and selective interventions and comfort-focused care. I kind of think of the full treatment for our longevity-focused patients. Selective interventions oftentimes apply to our patients who prioritize independence because sometimes some of the more invasive and aggressive treatments might then preclude them from having independence when they get through their hospitalization. Selective interventions can also be used for, kind of time trialers as well. And then comfort-focused care is the third one. And then just remember to wrap up. We like to thank our patients or families for talking about these things because these are oftentimes not easy things to talk about and are frankly scary things to talk about. So we generally like to thank them for being open to talking with us about them. And then we let them know that we'll document their values and the discussion that we had so that their healthcare teams know what's important to them. And then we like to end with kind of a supportive non-abandonment statement that we'll try to do everything we can to help them through this. So some take-home points. Again, it's important to kind of orient where your system is because during conventional contingency and crisis, our responses are a little different and our conversations will be a little different. The conversations that I kind of outlined today, I think are kind of ones that you would have in more of a conventional contingency state. If you go to the Vital Talk and CAPC websites, mainly the Vital Talk websites, there's another acronym there for how to have these conversations during a crisis state. So that might be helpful if your system is leaning more towards crisis capacity. And then where does your patient fall? Are they low risk, moderate risk, high risk? And I know that's getting slightly harder to tease out now that we've had several elderly patients who have been intubated on the ventilator and have recovered quite nicely, and other younger patients who have really struggled. But we do our best with the information that we have, and it's helpful to kind of try to sort out your patient within this framework, because that might change your discussion a little as far as when you present, some serious news about prognosis or help them make a plan for if something happens. If they end up hospitalized. Eliciting patient values, always important because that's half of the equation there, and their side of the equation is their values and goals. Assigning a healthcare proxy, again, if nothing else, sometimes this is the most important thing we can do during these conversations, and it might be as far as you get. Which is fine because at least there's hopefully somebody else out there who can help you make decisions in case anything does happen to your patient. So you're not left trying to get a guardian at the last minute while someone's critically ill in the hospital. true story, or without someone who knows anything about your patient. And then responding to emotion, again, just so important. It's a scary time. It's a stressful time. I think all of us have stronger, heightened emotions during this time, providers and patients. So, taking a deep breath before you jump into these conversations also quite helpful. And then being able to respond to your patient's emotion and being prepared to be confronted with big emotions during these conversations that are probably more stressful now than they are when we're pre-COVID. And I stole heavily from Vital Talk and the Center to Advance Palliative Care. Both of these sites have taken down their paywalls so that you can access a lot of this information for free. So please take advantage of that. And again, there's just a lot of useful language on these websites. And then if you are a fan of acronyms, definitely check out Vital Talk. And I'm open for questions, especially thoughts, ideas that you have that could, help me when I'm having these conversations with my patients as well.